Hello, everyone. Welcome to Aging Sensitivity and Communicating with Older Adults. Welcome to this module. Hi, I'm Elaine Gould. That's a picture of me from a few years ago, all dressed up at my niece's wedding. And I'm delighted to be able to do this module with you. I have been working with the Hartford Institute for almost 17 years, and I was director of programs for 11 of those years. So about this module, this is an online module, as you know, of the CNYGEC, the Consortium of New York Geriatric Education Centers. It was developed by the Hartford Institute for Geriatric Nursing at NYU and the College of Nursing. The three websites that you see listed there are wonderful resources. There are more resources at the end of the module, and I hope that you will avail yourself of them. The CNYGEC is a consortium of 4 academic partners committed to training a wide range of health and human service professionals and interdisciplinary faculty throughout New York State. And these are the partners: Mount Sinai, NYU, Columbia, and the GREC, which is part of the James J. Peters VA Medical Center. And this program is funded by HRSA. So the objectives of this module are really twofold. One is to define the 4 barrier domains to good communication with older adults and to really understand them. These are physical, cognitive, psychological, and socio-cultural barriers. And then we're going to spend a fair amount of time looking at techniques to break those barriers and to create effective communication with older adults. So let's get started. Each older adult is unique, and we all know that in theory, but it's a little bit harder when we actually have many older adults that we have to see in the course of the day. But our U.S. culture actually says otherwise, and we're going to talk about that for a minute or two now. Older adults range from vibrant to frail, and we each have our own unique perspective. And think about the answer to the question, I will be old when? Just take a minute and think about that. And what's interesting is the answers are group themselves, actually. Often for people who are younger than 40, we often get a number. Somebody will say that they're old when they're 65, when they're 82, when they're 99. However, if for most people who are over the age of 40, they suddenly start to see a slightly different perspective, and it's a perspective about function. I will be old when I can't do this and I can't do that. It's always about function and about loss. But what's interesting is that that unique perspective is never a positive one. It's never, I will be old when I feel wise, when I can impart some wonderful information to my grandchildren. It's always about a loss of independence and function. Other ways that really give us not such good interpretations of older adults are really stereotypes that we have. We have a lot of generalizations and trends and patterns, but we tend to group these. And so we end up with not such good arrangements. Also, there's the question of who decides when we are considered old. The government decides for us. It says that we're the age of 65, or for some of us, we're not old till we're 66. For some of us, we're not old till we're 67. So it's a bit of a slippery slope. I am now considered old by several people in the subway because they offer me a seat, and I very gladly take that seat on the subway in New York City. So we have a lot of ageism that happens in our culture, and it gets in the way of good communicating. So let's look a little bit more about the stereotypes. Stereotypes are a system of destructive false beliefs about older adults. Some healthcare professionals make erroneous assumptions based on age rather than on individual characteristics. We all know some unattractive characteristics of older adults, and if you think about those for a minute, I'm sure you can come up with some. Some people say they're grumpy, they're forgetful, they're nasty, they can't hear, they can't see. We all know someone who actually has those characteristics. The problem is when we clump these characteristics into a big garbage bag and we dump them on top of an older person when they walk in the door before we even say hello. So we need to be very careful about that as we approach older adults. And stereotyping really can lead to embarrassment, dissatisfaction, and poor quality care. So we're not talking about issues that are peripheral to healthcare. They really are central to healthcare. So the dominant view is aging in decline. There are multiple losses, chronic conditions, constant need for adaptation, and this leads to tremendous frustration for older adults. These are all true components for many, many older adults, but not for all. And there's a new growing view, and that's based on strength. It's called strength-based aging, because there are cultures who actually venerate old age. We see the glass, in this view, you can see the glass as half full, not half empty. We see the uniqueness in each person. This view doesn't deny decline, but just focuses on strengths rather than weaknesses. And it promotes participation and collaboration, and it really does create a more effective communication. So this is the kind of alternate approach that we hope you will begin to think about and utilize in your practice. We're going to talk more about this as well. Excuse me. So the aging process. Well, there's physical, cognitive, psychological, and social aging, and it happens at different rates for different people, just the way children have different rates of intellectual and physical and psychological development. Older adults have different levels of decline in physical, cognitive, psychological, and social aspects of their life. You will hear me talk about my husband's wonderful Aunt Flory. She was great. She died at 97. And she looked very, very frail, but she happened to have absolutely perfect hearing. But people would look at how frail they were, and they would go up to her and say, "Hi, Aunt Flory, how are you?" They'd yell into her ear, and she'd say, "I'm fine, and I really can hear you perfectly." So we have to be careful with this and not assume all these different kinds of problems when people may or may not have them. So the aging process happens unevenly. And again, we look to wellness programs to sort of slow this process. We want to what's called square off the decline curve. For many people, the decline is a series of plateaus, and then a drop, and then another plateau, and a drop, and another plateau, and another drop. And for many people, we want to have that highest level of functioning possible, and then a sudden quick decline and death. However, actually, not everybody wants this squared off decline. There are some people who want to know when they're going to die, and they want to plan for it. And so life is complicated because the aging process isn't the same for everyone, and what they want out of the aging process is not the same thing always. But there's a lot of atypical presentation for older adults. Diseases don't present themselves the same way. A heart attack in an older woman does not necessarily look like the pain down the arm that is the common way for younger people. She may describe herself as having indigestion. Medication has lots of side effects. And for many older adults, their main complaint is there is this vagueness in how they feel. They just don't feel good. And so it's very hard to diagnose often what's going on with them because they cannot communicate well about what's going on with their bodies. And so there are complicated multiple chronic conditions and geriatric syndromes that again complicate their lives and complicate communication. So there are broad geriatric syndromes. These are categories of signs and symptoms that are prevalent in the older adult population. They often have more than one cause, and they limit activities of daily living or instrumental activities of daily living. And they certainly reduce one's quality of life. This is a list that comes from the American Geriatric Society: difficulty swallowing, malnutrition, bladder control problems, sleep problems, delirium, dementia, vision problems, hearing problems, dizziness, fainting, difficulty walking or gait problems, falls, osteoporosis, and one that we have added actually called slow cognitive processing. So you know that many of your patients have many of these issues, and they complicate not only their physical problems, but how they can communicate about their physical problems. So let's take this little comorbidity quiz here. See if you can look at the diseases on the left and some conditions on the right and try to match them up. I'm going to give you half a minute here to look at that list. Now, of course, this is a trick quiz because there's really a simple, quick answer that goes with all of it. Everything goes with everything. So you can see that older adults are pretty complicated. They may have arthritis, but they may also have hypertension, congestive heart failure, some osteoporosis, some depression. They may have memory complaints. They may have mobility problems. They certainly could have aches and pains with arthritis, but they may have urinary incontinence as well, and they have more trouble with their urinary incontinence because of their arthritis. And so you can see that this all muddles together and makes older adults very complicated. And they may come to you in a clinical setting for a particular episode of illness. However, you cannot disregard all the other things that are going on because they can have tremendous effect. And all of this, amazingly enough, affects communication. So that's a sort of general overview tapping into older adults and some of the societal issues. So I want to focus now on why do we communicate? We have this as a module because, again, as I said, this is not a soft, extra kind of topic. This is really, really central to good communication, good healthcare for all patients, but certainly it's very important with older adults. So why do we bother to communicate? Well, it's basically to have our needs met. We have something that we want to tell somebody else about. We want something that we want something done about something. So we have a need to communicate, and that's why we do so. We're just not passing time and talking about the weather when we do a lot of communication. Sometimes we do that, but not all the time. So miscommunication is a real problem in healthcare because we can get diagnosis errors, we miss symptoms, we get treatment errors because we have missed opportunities for treatment and management. We have poor patient education and a lot of adherence issues. We have poor quality healthcare, and we can have inefficient use of resources. So good communication is really central to good healthcare. Let's talk now about some fundamentals of good communication. These are very simple ideas. It's not rocket science, but the important part is we hope that you will think about them when you are in a conversation that is not going well, because if you can recognize these fundamentals, you can really start to think about what you can do to change the course of the communication episode and make it better. So the first one is that communication is a two-way activity. I say hello, you say hello back. Well, that's not always what happens with older adults right out of the barn. There's a receptive component and there's an expressive component. Sometimes older adults won't be able to hear you. Sometimes they don't speak the same language. So this two-way activity is not always in working order with older adults, and it's the very first thing that you need in order to even start a conversation. So that's the first fundamental, a two-way activity. The second one is expectations. If I were to say, if somebody said hello to me, and I were to respond back and go, boo, you would say, oh my goodness, what's going on here? She's supposed to do something else. She's supposed to say hello back. Well, that's the whole point. You expected me to do something else, but I didn't follow your rules. So experiences and belief structures really do create expectations. And older adults actually expect to have your full attention. They expect to have their problems solved. And they will leave health plans and providers if their expectations are not met. So satisfaction surveys become increasingly important because people bring their expectations to these surveys. And their expectations may be completely unrealistic, completely off the wall, but they are bringing them to those surveys and to their interactions with you. And you are not a blank slate either. You bring expectations about the older adults to the situation as well. So it's very important that we understand that we have expectations and what those expectations are. So look at this slide, and I want you to see, what do you see first? Do you see an old woman or do you see a young woman? And whichever one you see first, then try to look at the picture and see the other one. So I'll give you a few seconds to look this over, see what you find, and I will tell you that this is one of those dual pictures. Both the old woman and the young woman are in this picture. The young woman is looking away. She's a young Victorian woman. She has a black choker necklace. She has a cheekbone. You're looking at the side, and there's her ear, and her eyelash and itty-bitty nose are sticking out on the left. To see the old woman, she is often considered, what would say, an Eastern European woman. She is wearing a babushka, a scarf. She has a very large nose. What was the ear of the young person is the eye of the old woman, and the choker becomes her slit of a mouth, and she has a very long pointy chin. So I hope that you can see both sides, both images in this picture. The reason that I put it in this slide deck is because we don't all see the same things at the same time. So finding a shared reality is difficult, and we cannot assume that we have each other's perspectives all the time. It's hard work to see another's perspective. We can't force a perspective on one another. We can only try to find common ground. And so you need to be aware that your patients may have a completely different perspective than you do on their illness, on what's going on for the day, what they want to have accomplished in their time with you. All of those things are different. And we need to find what we call common ground. Now, common ground doesn't have to be large and philosophical. You don't have to sit down with a patient and find big common ground. You want to find just enough common ground so you can get the job done for that moment in time when you are having a clinical encounter. And so what you may need to do is ask for perspective and expectations in a respectful way around the topics that you think are relevant for that particular clinical encounter. And we're going to come back to that notion of common ground again as well. So another of these fundamentals is finding a shared reality. And finding a shared reality is difficult. It's not easy, and it cannot be assumed. Another fundamental is comfort. Comfort is critical in situations because comfort creates trust, and trust is vital to adherence for everybody agreeing on what's supposed to happen. And it's your job to make people comfortable. And so it's your job to reach out and to try to create the trust. And the last fundamental is active listening. Listening is not the same thing as hearing. Hearing is a biological process. listening is a cognitive process, and listening is a vital component of the clinical encounter. You need to be listening carefully to these slides, and I hope you're not doing your email while I'm talking to you. But active listening is very, very important, and active listening is harder to do at the end of the day than it is in the beginning of the day, because you're tired, you're distracted. All of those things can get in the way of good listening. So these are the fundamentals. There's 5 of them, and it's amazing actually that we communicate as well as we do, because it's so hard to have all of these 5 components functioning in optimal and in working order when we have a communication encounter. But if you think about them, I like to think of it as having a sort of out-of-body experience. When you're in an unproductive conversation, try to pull back a little bit and hang out there above the conversation and say, what's going on? Which one of these 5 things, or maybe is it all of them, that we just don't have? And how can I try to get some common ground with all of these activities so that we'll have better communication? So the communication process has 3 parts. There's a perception. You take stuff in, you mull it around in your brain, you evaluate it, and then you put something back out. You transmit, again, in some usually verbal form. And so this is a 3-part process, and it's actually very complicated. And it's complicated by all kinds of barriers that get in the way, and we're going to talk about those barriers in a minute. But it's interesting that we know that there's content, we know that there's vocal and tone quality, and we know that there's body language when people communicate. And which one of those things do you think is the most important? Well, now you'll see if you've guessed correctly. Well, body language and vocal tone quality create 90% of a conversation, with the content that you want to impart only 10%. Before anybody even says a word, their body language will tell you a lot. Are they angry? Are they bored? Are they diffident? Vocal tone quality can also have a huge effect to show whether somebody's impatient or whether they're loving or they're respectful. So before any content is imparted, you need to really watch what you're doing with body language and vocal tone quality, and also be aware of what the older adult may be doing with those components, and maybe that there are some barriers in those that will get in the way of having people communicate well with their body and their vocal tone quality. So let's move on to what are all these barriers now to good communication. We know the components of what good communication should be, so let's look at the barriers. And there are 4 of them. There's physical barriers, there's cognitive barriers, there's psychological barriers, and there's socio-cultural barriers. So let's start with physical barriers. Hearing, vision, speech, and movement. Well, I'm sure many of your patients have hearing loss. The definition is often decreased ability to hear high-frequency tones. And there are a lot of causes: nerve deterioration, diseases, environmental situations, medications, even earwax that can get in the way. And I have here what we call an unfair hearing test, which is from the League for the Hard of Hearing, and it's actually now called the Center for Hearing and Communication. And it will give you an idea of what it's like to have a hearing loss, and then what it's like to have some hearing aids. So take out a piece of paper, some scrap paper. You're not going to be handing it in to me. And see how well you do. I can guarantee you that it's not going to be as easy as you think. So here we go.
Chosen so that they are easily confused with other words which sound much the same. And we have rigged the test to prove a point. You will hear the list of words 3 times. First, filtered as though you had a slight high-frequency hearing loss. People with this degree of impairment often do not even realize they have a loss. In fact, they get very indignant when their friends suggest that they may have a hearing problem. At other times, they're very frustrated because they think everyone is mumbling, even when they're not. We will also speak just a little softly, so you will have to concentrate hard on hearing the words correctly. You are to write them down. We think you're going to have a little problem getting them 100% right. Remember, we are giving you a little hearing loss as you listen to the test. Go ahead, try it. Write the words in column A on the worksheet. Here's the list. Ready?
Number 1, filled. Number 2, cats. Number 3, thumb. Number 4, heat. Number 5, wise.
Now, we will repeat the list without eliminating any of the high or low frequencies, just as though you had normal hearing. But again, just a little softly, so it isn't too easy for you. This time, use column B to write them down.
Number 1, filled. Number 2, catch. Number 3, thumb. Number 4, heap. Number 5, wise.
Was that better? Good. I'm still not willing to bet that you got them all right. There are some tricky words on the list. Now comes the interesting part. This time, instead of filtering out the high frequencies, we are going to put in a little more of them. It will sound as though you are wearing a hearing aid which is compensating for your hearing loss by giving extra emphasis to the frequencies that you don't hear so well. Try it once again. This time, write the words in column C.
Number 1, filled. Number 2, catch. Number 3, thumb. Number 4, heap. Number 5, wise.
Okay, so I hope you enjoyed that experience. It was probably the longest 5 minutes of your life. But there are, and I'm going to talk about how you responded to those in just a minute. But there are communication consequences, really, for hearing. Decreased speech discrimination, miscomprehension of speech, difficult telephone use, difficult face-to-face interaction, inappropriate, awkward, or selective hearing, daydreaming, social isolation, deterioration of speech and voice quality. And all of those actually happen when people don't hear well. So you have to think about some of those things because they're going to get in the way of good communication. Vision loss also is another one. Obviously, it's decreased pupil size and accommodation can happen. Macular degeneration, which is central vision loss. That's the second picture. The first picture, of course, is decreased pupil size. The second one is macular degeneration. The third one is glaucoma, where you have peripheral vision loss. You can see in the middle, but you can't see on the outside. And cataracts, which makes everything cloudy all over. What's interesting, particularly with macular degeneration, is that because you don't see in the middle, body language can often get distorted because people have to turn to one side or the other because they actually can only see in the periphery and they need the person they're talking to in their peripheral vision rather than straightforward in front of them. So that often distorts body language. So vision loss has, again, some communication consequences, and you're going to start to see some common elements of all of these physical losses. Specifically, inability to identify doors, stair edges, light switches, avoidance of light sources which cause glare. Patients will stay in a dimly lit room and have social isolation. They will just stare mindlessly at a television. They will have an inability to talk about what one is viewing or seeing so that they cannot participate in social conversations as easily. Even though they can hear, they can't see as well. They sometimes will appear inattentive, and their body language may appear inappropriate. In addition, there's speech losses, and there's lots of causes of those, which I'm sure you know. Stroke, aphasia, the loss of ability to speak, or agnosia, the loss of ability to recall words. And then dental difficulties, which people often forget about, either the lack of teeth or ill-fitting dentures. Our lovely Aunt Florrie had very ill-fitting dentures, try as she might, and she had enough financial resources to do better. However, she was getting jawbone deterioration, and so her dentures would, after a few months of having a new set, they would get loose and she'd start to talk and then they would flop down. And it was so embarrassing, and she just wouldn't talk as much because she was afraid of being embarrassed by her dentures. And then there's something that we often also forget, don't think about, is xerostomia, which means dry mouth. And a lot of the medications that older adults take, particularly for heart conditions, have the side effect of dry mouth. And if you've ever had dry mouth, if you speak a lot, you will understand that your tongue sticks to your teeth and your mouth just doesn't work as smoothly. So these are very important causes of speech problems. And if you have speech problems, you're just less likely to talk. You're only going to talk when you absolutely need to. And again, these are some of the communication consequences: loss of self-esteem, embarrassment, isolation, and frustration. And even touch and movement can cause communication problems. Neurons die and are not replaced. Stroke, arthritis, osteoporosis, lack of exercise, weight gain, muscle atrophy, vulnerability, fear of falling. All of these means that people don't move as well or as agilely as they did before. And so again, you have body language may appear inappropriate. Feelings of fatigue lead to lethargy. Limited stamina may lead to loss of an initiative and cooperation with caregivers. Amazingly enough, these things that you may not think about all have a consequence for communication. And even amazingly enough, smell and taste. It is sometimes part of what's considered normal aging. Certain disease states can bring on the loss of smell. Medication and dry mouth means that you don't taste and smell as well. Dental and periodontal diseases, surgical interventions, environmental exposures. I had a very bad cold a few weeks ago, and I lost my sense of smell and taste for about 4 or 5 days. I was totally horrified that I would never be able to enjoy food and talk about food and cook food. And how would I know when I cooked something it would taste all right, because I couldn't taste it. I was terrified, and it had an enormous emotional consequence on me, and ultimately what I thought about talking about and how I was participating with people. So again, reluctance to discuss food, reduced pleasure and comfort in eating, nutrition and immune deficiencies, and decreased socialization. So all of these things all of these sensory losses have an effect. Now, you took that unfair hearing test, but you can also, I cannot do it through this module, but I would encourage you to get earplugs and some sort of cloudy glasses. Put a little Vaseline on your glasses and take some sort of gloves and put all those things on, and you will see that multiple sensory loss is 10 times worse than any of those single sensory losses, because you can't multitask anymore. It's very hard to focus, and it brings on isolation. And your answers to that hearing test were quite similar. Most people have a tremendous sense of frustration. You had picked up your pencil, you thought you were going to move forward, but what happened? You couldn't hear those words. And try as you might, the first 2 words you try to write down. By the third one, you lean forward, because maybe if you can't hear it, maybe you could sort of hear it more carefully if you got your face closer to the computer. And then some people just put their pens down and give up and don't even bother to try anymore. So there's enormous frustration, and frustration leads to 3 responses, emotional responses that you need to be aware of with older adults when you communicate with them. The first is aggression, You can get angry. You can't hear because other people are mumbling. It's their fault. It's their fault. Why can't they just speak up? And people get angry and nasty and impatient. The other response with frustration is withdrawal. It's too hard. I can't talk. I hurt. I've got dry mouth. I can't hear. I'm just going to withdraw. I'm not going to have small talk anymore. I'm only going to say yes or no, whatever I can do to get the job done really fast. And they withdraw. And the third one is embarrassment, also called conciliatory resistance, where patients will yes you to death. They are embarrassed to tell you that they don't understand, and they don't want to be disrespectful, and they don't want to disagree with you. So they will go, yes, 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 I understand, and they have no clue as to what's going on. So yesing you to death is not, you cannot assume, there we go with that word, assume again, you cannot assume that they have any understanding of what's going on, with simply an acknowledgement of yes when they say they do. So that's why there's something called teach back, which is a way to make sure that people really understand what's going on. You get them to explain, and we'll get into that in a little bit as well. So all of these sensory losses lead to frustration, and frustration leads to aggression, withdrawal, or embarrassment. This is one of the most important things for you to remember out of this whole module. And I hope you will recognize those aggressions and withdrawals and embarrassments and try to deal with them. Particularly aggression. If someone is nasty with you, you shouldn't take it personally, because most of the time there's reasons that people do things. And often they stem from physical losses as well as ultimately emotional or cognitive ones as well. So there are a lot of physical barrier breakers that we call, things that we can do that will help if someone has a lot of sensory losses. So first is to recognize the frustration, validate it, and that you understand that it makes you grumpy. It's certainly to say these things to get to talk about the elephant in the room, this notion of frustration. And recognize and validate the sensory loss. I understand that you don't hear so well. And optimize the function. Are they wearing hearing aids? Are the hearing aids functioning? Do they need to change the batteries? Utilize the best senses of an older adult when you're talking with them. If they can't hear so well, then you focus on seeing. Give them more visual aids. If they can't see, then you give them more auditory input. And one of the most important things you can do is avoid sensory distractions. Turn off the radios, the intercoms, close the door. Make sure that they can focus just on you with a lot of distractions. When my mother turned 90, she had excellent teeth all her life, but they finally gave out on her when she was 90, and we started going to a variety of dentists. And I pleaded with them to turn off the music, to turn off the TV, to at least take off their mask when they were speaking with her so that she could see their mouth and hear them better. These are small things that don't take any money to do, but they take sensitivity and respect for the older adult. Again, don't shout, but you can lower the pitch of your voice. I'm doing this now because so much sensory loss is from the high voice range. Women are not heard as well as men. Now, you can't talk this way for any length of time, but women may be able to do this when a particular word or sentence is just not getting through. Sorry, I have to go back to my regular voice. Okay, ask if pain is a distraction. Pain can be a huge distraction for people and a huge barrier for good communication. If you have serious pain and constant pain, you will know how serious this is. And again, read body language and recognize that it may be altered. Sometimes older adults can actually look like they're demented or kind of crazy, and it's just because they're compensating. Adapt materials to the sensory loss. Use large print and dark print materials. There is absolutely no excuse in this day and age of computers and printers to give them material that's been Xeroxed 100 times and has tiny print on it. It's simply unacceptable. And the last item for hearing for sensory loss is portable amplifiers. I don't know if you know about them. You can buy them in places like Radio Shack or Best Buy, and they hang around a patient's neck and with earphones on, and they're excellent for stationary environments where somebody is sitting and listening. They are great for people who need to have their eyeglasses and their hearing aids and their teeth taken away from them if they're having day surgeries. They can wear this until they're absolutely under anesthetic, and they've been very, very helpful, and they're very inexpensive. Again, adapt scheduling and mail medical history forms home if you can for prior completion. And don't appear hurried. That's the most difficult thing for healthcare professionals, because we know how harried and hurried you are. But if you can try to give them some undivided attention, you will have a much better outcome. And just a quick note on taking an environmental audit. This is looking at what's going on in the environment, in the waiting rooms and in your clinical encounter spaces, and look at what's happening with access, design, and space planning. Can two people fit down an aisle? You really need to have at least enough space for two people, because either someone will be escorting the older adult, or they will be coming with a caregiver, or they will have a walker or a cane, and they just need more space. Furnishings need to have chairs. Signage needs to be big enough and low enough, not so high up, because many old women are short and they don't look up. Temperature and lighting also, it shouldn't be too much glare, and it should be a little warmer, particularly if they're taking off their clothes. Watch out for the noise level, as I discussed, and watch out for and make sure you have good reading and writing materials. So that's all about the kinds of things that you need to look for, and tricks you can do if you see patients with these sort of sensory losses. So now let's move on to cognitive barriers. There's really two kinds of cognitive barriers. One is really a slower cognitive processing and a loss of executive function. Let me just see. Oh, yes. Okay. I will start with that. Slower cognitive processing is interesting because they actually hear, but they often think that they don't hear. My mother was always one beat behind. We would sit at the table and somebody would say something funny, and everyone around the table would laugh, and then we would go on to another topic, and then my mother would laugh because it took her that extra beat to sort of figure out what was going on. She was not demented in any way, shape, or form. She was a high-level executive and worked until she was 87. However, there was some slower cognitive processing going on. And what you can also get is a loss of executive function. Now, this has to do with how organized people were when they were younger. Some people are very disorganized, but they follow directions more slowly. They have difficulty adhering to care plans. This has nothing to do with dementia. This is simply a slower cognitive processing that goes on with many older adults. There's also chemical dependency. And what do you think the chemical of choice is for the current cohort of older adults? And I will tell you that it is alcohol. And it doesn't take much. Someone can have one drink. They don't think of themselves in the evening having a beer or a glass of wine. They're certainly not considered alcoholics, and yet it could certainly slow down responses and make cloudy effects. It's going to be interesting when the baby boomers bring marijuana to the nursing home, what's going to happen with that level of chemical dependency. Polypharmacy is another one. It also brings on a slow, cloudy effect. Again, my mother would take some, she had congestive heart failure, and she would take some medications, and they would just, she said, they would just make her cloudy and slow. If you see those Claritin ads, they have a foggy atmosphere, and then they peel it away, and everything's bright. Well, polypharmacy can do these kinds of things, and what's therapeutic on day 1 and day 5 and day 7 is suddenly toxic on day 8 and day 9. So we have to watch out. If people are look like they have dementia or they look like they have delirium, the first thing to think of is drugs. Are the drugs doing something that is clouding and affecting their sharpness? Dementia, of course, and Alzheimer's disease in particular, is a terrible cognitive disease. It is tragic. And what's really tragic about it is that older adults, if they have this disease, lose a sense of context. Now, everybody forgets where they leave their keys. That's not what's going on here. If you have loss of short-term memory, you lose context. That means that you don't remember from moment to moment what that something that you're sitting at is a table, that you have someone you know sitting next to you, because you don't remember them. They are new. You don't recognize food as something that you're supposed to eat. All of this, every single thing at every given moment is new, and therefore it's frightening, and it brings on tremendous aggression. When you see examples of an aide bringing a woman down to rehab, and he says, "Mrs. Jones, we're going to rehab," and she says, "Where are we going?" And he repeats, and he says, "We're going to rehab," and she says, "Where are we going?" And she builds up this aggression over and over again, and the problem is the aide keeps giving her the same answer, which is not helpful. But what is she really saying? She's not saying, "Where are we going?" She's saying, "I don't know where I'm going, and I don't know what rehab is, even though I went yesterday." And so that's the kind of terrible communication issues that we get into with dementia. And it's so important to understand where the aggression comes from. It comes from an emotional base, because emotions, amazingly enough, are what we keep for the longest time in any cognitive deterioration. So the emotions are there, so we need to deal with the emotions. And so the better response would have, to Mrs. Jones was saying, we understand that you don't remember. That's perfectly okay. Rehab is this, that, and the other thing. It's where you're going to do some exercise. It's right around the corner. Just have a soft-spoken conversation, and her aggression will be reduced. So another cognitive barrier is inadequate sleep. And amazingly enough, older adults actually get the same amount of sleep that younger people get, but they get it in batches. And that's why older adults take naps. And so they will feel more tired and need naps to recuperate. And so when somebody's tired and sleepy, they're not going to be as cognitively sharp. Additional barriers are personality types. We either want to do good, or we're very often people are aggressive. Anxiety is a huge, actually these are, those are the cognitive barriers. The psychological ones now are related, but they have a different focus. You have different kinds of personalities, people who are outgoing and people who are shy and people who are aggressive and people who want to do good. And anxiety is a huge psychological barrier, because it is a huge barrier to listening. It is well known and documented that if someone gets bad medical news, the next 15 minutes are completely useless. You can say all kinds of good things, you can give them directions, they're not going to take in any of it if they are anxious. Depression is another psychological barrier. It is a real state. It's different from sadness, and it really needs a clinical diagnosis, and things can be done with depression. There's also personal history can create psychological barriers. People can have lots of personal losses, and they can have a lot of bad healthcare experiences. They have what I call baggage and garbage, and they bring it in garbage bags and they dump it on you the minute they come into a clinical setting. And so you need to recognize these. In addition, you need to recognize what we call as a professional prism. Each of us has spent a lot of time and money becoming the professional that we are: a physician, a nurse, a social worker, a pharmacist, a PT, an OT, all kinds of these wonderful professions. And it's taken a lot of money and time and effort. And they give you a particular perspective, and that perspective is very important for your profession. However, what we need to recognize is it's not the whole perspective. Unless we have the perspective of the patient, and unless we have a multidisciplinary perspective, because older adults are so complicated, you're not going to get the whole story. So you can start with yours, with your view, but it shouldn't be the only view that you think about. And here is an example of this. Nurses tend to help. If you think about a patient who's not eating, the nurses will help them eat until they can gain function. For the physicians, they will look at more nutrition problems, but they will funnel it down to a B12 shot or a feeding tube and then pass the patient back to the nurse. And for social workers, we see societal issues. We see that nobody loves them, they don't have enough money, they can't get downstairs. And each of these views is valid about the person who's not eating and has nutrition problems, but each of them is just insufficient, and you need the patient's perspective. So what are some of the cognitive and psychological barriers? What are the consequences, communication consequences for all this? Some of this I think are pretty obvious, but it's important that we list them out. One is difficulty in achieving a shared reality. It's hard when you have all of these barriers up there to try to see other people's perspectives. Older adults have a lot of problems doing it, and you will have a problem trying to get your viewpoint to be understood by them. And you get this notion of frustration, bringing irritability, withdrawal, and aggression, acting out behaviors, and anxiety. These are the consequences, and you need to recognize them because they are important behaviors that absolutely affect how we communicate and whether we're going to communicate well. So what can you do about this? Well, use short sentences and avoid and. Take one thing at a time. Elicit yes and no responses if possible by using closed, not open-ended sentences. Sometimes older adults will come and you will be the only source of socialization for the day, and they are happy to talk about all kinds of things and ramble on, and you have 15 minutes for them, and so you try to keep them on track. However, you do have to realize that sometimes a little background is important in getting to a good diagnosis. One of the most important things you can do is alert the patient to a change in subject. Now I'm going to talk about your medications. That allows that extra beat that my mom needed in order to move forward and to keep up with what was going on. You say what you're going to do, then you're going to do it, and then you say what you did. So repeat and restate your message and look for meaning behind the actions and go slowly. Look through the older adult's prism. Recognize expressions of aggression and withdrawal. Validate the frustration, the anxiety, and depression. Get the elephant out of the box and right in front of us and look at it. Validate the problem. You can sympathize. I understand that you don't hear well, that you're depressed, but don't legitimize it. We're gonna plow forward and do the best we can. We're gonna optimize function. And again, you should see resistance as a source of information. When people don't do things, there's usually a reason. They don't wake up in the morning and rub their hands together and say, how can I make my healthcare professional miserable? There's a reason that they're not doing what you've asked them to do. And that's important to create trust and have a better source of communication. And again, involve the older adult and the caregiver in finding solutions. So in addition to the physical, we've gone through physical barriers and cognitive and psychological barriers. We're now going to look at socio-cultural barriers. And for a greater depth on this topic, I recommend that you look for the Cultural Competence and Chronic Disease Management of Older Adults module in this GEC. But I'm going to touch on some of the basic components here. So, understanding another's perspective, beliefs, attitudes, assumptions, and behaviors so that we can work together is what cultural competence is all about. And cultural competence is just one part of the basic issue of effective communication. And central to that are beliefs. We all have beliefs, and they have tremendous impact on healthcare. Beliefs, attitudes, and values affect what you perceive, how you process the information, and how you act with customs, behaviors, and words. Those are the three parts, the take-in, the processing, and the expressing back out. So there are 5 areas of beliefs that impact on healthcare. And again, you can't sit down and have philosophical discussions with your patients, but it is certainly appropriate to understand these and ask respectfully about these 5 areas. We've reduced it to 5 areas that we think have the most important, 5 belief areas that have the most important impact on healthcare. And the first one is respect. Who gets respect? How do you show respect? Do you tell grandma that she has cancer? Do you ask a doctor for a second opinion, or would it be insulting to him? Do you look someone in the eye? Do you shake their hands or not? Does the older son do all the make the decisions and the older daughter do all the work? So respect, every culture has a notion of respect and how they deal with it. And every culture has a notion of nutrition and medicine. What you eat, what's important, how different cultures have cured diseases. We have a Western medicine approach, but there's Eastern medicine, there's alternative medicines, there's medicines from every culture. And unless we understand those, we're not going to have the full story. My grandmother was an Eastern European Jewish background, and she believed in chicken soup and Vicks Vapor Rub, and that was it. That was enough. Oh, and maybe Epsom salts too. Those 3, and that was all you ever needed. The other belief structure is pain, and I should add here actually pain and suffering. If someone thinks that they should be suffering, then they're not likely to want to take pain medications. If they think that pain is simply a biological process, then they are more than willing to have medications that will ease their pain. Death is another one. Every culture has a notion about death. What happens when you die? How do you know you're dead? How do people know you're dead? What happens after you die? What happens to the people who remain? How is death expressed? These are very important issues, and each person really has their own take on all of these, as well as a basis of belief structures that come from the culture in which they grew up. And the last one is time. Time is interesting. Time is understood by everyone, but viewed very differently. Western culture has the notion of a clock. Other cultures do not have a notion of a clock. There are cultures that don't know what an hour means, what a minute means. They tell time by the sun or by the rooster crowing. In some cultures, it's nice to be a few minutes late. In other cultures, it's insulting to be late. So you have to ask when you don't know, when you think that these are impacting the conversations that you need and the communication you have to have in your clinical encounter. So we often don't know each other's rules of the game, and so we don't know how to behave with each other. And that's what happens. These beliefs lead to expectations. Back again to our expectations and assumptions. So there's one model that's really interesting in terms of how you can try to get cultural competence in your clinical encounter, and that's this LEARN model, which takes the first initials of each of the component parts. So you need to listen to the patient's perspective, explain and share your own perspective, acknowledge the differences and similarities between these two perspectives, recommend a treatment plan, and then negotiate a mutual agreed upon treatment plan. Because again, if someone doesn't agree with you, if you don't have common collaborative goals, they're not going to be adherent. You can recommend the gold standard, but if they don't do the gold standard, it has zero efficacy. If you can negotiate something that you think is second best, and it may well be second best, only 80% effective, but they'll do it, you're 80% ahead of zero, and that's so important. And again, when you negotiate with a limited time period, because often people will be happy to try anything for a while because they can come back and still save face and say, this doesn't work for me, what else can we do? I want to just touch on this notion of low health literacy because it has a tremendous impact, again, on communication. Obviously, there's the fundamental literacy of how literate people are in their native language and how they are in English, their ability to read and write and understand both their native language and English. But also science literacy is really important because they're not going to understand the terms that you're going to use. They don't know how their body functions. Amazingly enough, many people do not know that. I have a funny story of a physician who said that he was doing an annual review on a patient, and he told her that he was so pleased that she was really so healthy, and she looked at him indignantly and said, "You haven't talked about my prostate." And he said to her, "Well, women don't have prostates." But she didn't know that because she's seen a lot of ads on TV of everybody's worried about their prostate. And so she didn't think he was a good doctor because he wasn't talking to her about her prostate. So amazingly enough, that is a true story. So people don't know how their body works. They don't even know the names of all the body parts. They don't know the difference between a virus and a bacteria. So they don't understand why you're not giving them an antibiotic if they have a virus. They just don't understand. They don't understand cause and effect. They have a different notion of cause and effect. It may be much more religiously based than your scientific basis. They don't understand the concept of a therapeutic dose. Why is it important to finish all that antibiotic when I feel better after 2 days and I could save some money and put it in my cabinet? So, and then there is the amazing example of not understanding sort of language where the word ONCE in English is pronounced once, but in Spanish it's once, which means 11. And amazingly enough, you can have huge discrepancies in and problems in dosing and adherence issues with some language problems too. And so that leads us to this notion. All this time we've been talking about communication, and it's only now that I even talk about language, because language reflects and creates reality. What I mean by that is, first of all, it reflects. We use language to, again, talk about our needs and talk about what we're concerned about. I have a pain in my leg. It describes things. It's raining outside. But for some cultures and for some people, it can create reality too. My grandmother was always, when people would say bad things, she would always poo-poo and take her arm and push the air away of it as though she were pushing the bad spirits away. Some people won't say the word cancer because they're afraid they're going to get it if they give a verbal reality base to it. So that we really need to understand, and people use language incorrectly. They say stomach when they actually mean their belly and their intestines. So we use language poorly, and yet it can lead to tremendous misunderstanding. And then in addition, of course, it's when we speak different languages and we need translation, and the difference between translation and interpretation. Translation is the word for word, give me what you got. Interpretation is a summary. And if at all possible, you want to have professional translators, because they will give you as much word for word as possible. And if you have family caregivers, you're going to get much more interpretation, which is their view and their take on the scene. And it probably isn't the patient's take on the scene. So again, what are some of the barrier breakers? Well, you need to develop trust, and you do that by getting the monster out of the box. And it can often be done as simply as, I understand that. You can't hear, you're worried about this, you're depressed, whatever, you've got a pain in your leg. That brings a tremendous notion of meeting someone where they are and finding some common ground. I understand that your religion is very important to you. All of these kinds of things. Just try starting with, I understand that. You need to ask questions. Asking questions in a respectful way is perfectly fine, and it creates trust. You need to ask about relevant beliefs, about other healers, and other remedies, because you won't get the whole picture unless you do that. Ascertain the literacy level in a native language in English. Speak slowly and distinctly, but not too slowly, because you will lose cadence when you do that. The rhythm of language also helps comprehension. Avoid ambiguous statements, avoid metaphors, recognize different abilities to understand and speak English. Again, with translators and interpreters, separate the agendas of the patient, the interpreter, and the clinician. You can set the rules for the interaction, and they will follow them. Communicate with the patient. Ask for word, not summaries from the translators. Review for comprehension, and separate meeting and have a separate meeting if you need to with the family translator who's also the caregiver. Again, we need to talk a little bit about caregivers and communication, because they are often such a central part of older adult care. And there's an issue of balancing the caregiver involvement and patient privacy. And the disability level and the cognitive capacity of the patient will sort of determine how much you can deal directly with the patient and how you have to deal with the caregiver, but make sure that the patient is not excluded. And you also need to know the responsibility level of the caregiver. Look for caregiver stress. What are they capable of doing? What are they confident that they can do? How burdened are they? Because caregiver burden is a huge issue, and you will have lots of miscommunication when caregivers are burdened. Don't ignore either the patient or the caregiver, and again, separate the agendas so that you give each of them the respect that is due. So again, these are summaries of barriers to good listening. There's lots of barriers to good listening. We don't listen well. We may hear, but we don't listen. And these are some tips for good listening. Be patient, listen attentively, don't interrupt, listen for understanding, listen for cues, read body language, exhibit body language yourself, understand an adult's frame of reference. And assessing an older adult's understanding is interesting. You should not, you look for nonverbal attentive behavior, look for relevant questions, ability to repeat what you've said. That's the teach-back notion. You may encourage note-taking, but don't count on the smiles and the nods of the agreements or the absence of questions as understanding. They probably are clues to a lack of understanding, actually. And just another note of clarification is that understanding is not the same as agreeing. And that's where people have this conciliatory resistance. They will say, yes, yes, I understand, yes, yes, that's all good, and they go home and they don't do what you want them to do. Because they are not agreeing with you. They're understanding you, I get it, but they're not going to do it because they don't want to and they don't agree with it. And that's where this notion of resistance is not bad. Resistance is a form of information. You will find out what they don't agree with and what they don't want, or what barriers are in the way. So use open and closed questions when appropriate. Closed questions are yes and no answers. Can you do this? Do you do this? Have you had this? Open questions are descriptive answers. How do you feel about this? What happened? Why? And listen to what people tell you. That's really important. And helping an older adult prepare for a clinical visit, what kind of transportation do they need? To ask them to bring their medications or an accurate list, to bring their questions written down because they forget, and in the moment and in the time pressure of a short amount of time, they may be flustered. One of the most important things that you guys can do is give older adults written instructions to take home. This is reminders of exactly what they do. And to give them a telephone number of someone that they can call if they need clarification. So meeting all these communication challenges. So these are some things you should remember. Resistance is not bad. It's in fact a source of information. Problems that in fact can be opportunities. You can learn from situations to improve quality of care. Repeated frequent questions or situations should be looked at for systemic solutions. If they're coming up a lot, there's a reason that they're coming up a lot. And there are no silly or stupid questions. If somebody doesn't know and they're brave enough to ask, then they deserve a respectful answer. And if you can solve problems, it leads to tremendous patient loyalty. So resolving problems, how do you do that? Well, the first thing you do is listen. You ask some questions. You repeat issue for clarification. You show empathy and validate the concern. I understand that you had a terrible time doing this, that it was very frustrating. Be clear that you will help immediately if at all possible. However, you can discuss options and negotiate an agreement on next steps. And these are the kinds of things that people at the front desk can be, if the front desk does these, it will go a long way to create trust for everyone and goodwill. So multiple problems and barriers are common. Multiple chronic conditions are common. And remember that it's up to you to adjust the physical environment, the social environment, organizational environment, and your personal approach. So I will leave you with my favorite quote, which is from a book by an author, Chaim Potok, called The Chosen. And a son is going off to assimilate into American society farther than his father would like, and the father says, "Come back as far as you can and I'll meet you the rest of the way." And I like this because it basically states what we as healthcare providers should do with all our patients, and certainly with older adults. You want to optimize function, but be respectful of where they are, bring them back to some kind of as much common ground, and then you meet them the rest of the way to get to wherever they are. So thank you very much for attending this module. We hope it's given you some good insights and some useful information for you to try to utilize in your practice. These are references and resources. There are books and articles as well as websites. And I extend my congratulations to you on the completion of this module. Thank you so much for being with us.